I will go ahead and welcome everybody back to the afternoon session. I hope you've been enjoying the morning sessions, enjoy them as much as our team has. We're so thankful to everyone for speaking. I want to reintroduce to you my wonderful colleague, Nancy Peterson. We've also got Dr. Susan Hintz here, who's going to join me after for the Q&A, which we're looking very much forward to. So Nancy, I'd love for you to kick off the afternoon.
Thank you. I hope everyone enjoyed their break and maybe got out and got a walk going. But I am so honored to be able to introduce our afternoon speakers, and especially the first two, because I've had the pleasure to have worked with them, and they are brilliant and just wonderful, down-to-earth people, human beings. So I'm really excited to be able to introduce them. The first session of the afternoon is a recorded session by Dr. Yair Broomfield. He's the professor of OBGYN and the maternal fetal medicine at Stanford. He is also the director of the fetal therapy at Lucile Packard Children's Hospital. His talk on fetal surgery for fetal bladder and kidney anomalies brings the world of technology and medicine together for you in one session. He is currently traveling, so in his absence, Dr. Susan Hintz will be handling the Q&A portion of Dr. Broomfield's presentation. She is a board-certified neonatologist and perinatal epidemiologist at Stanford. She has over 30 years of clinical experience and currently is a Hess professor in neonatal and developmental medicine at Stanford. Dr. Hintz serves as the director of Stanford's Fetal and Pregnancy Health Program, which she helped establish in 2009, and as the medical director of CPQCC's High Risk Infant Follow-up Program Quality Care Initiative. She has also co-authored over 300 publications, and she currently serves as the principal investigator for several studies in the NICHD Neonatal Research Network. Her research interests include early childhood neurodevelopment outcomes and morbidity and mortality of extremely premature and high-risk infants, as well as the use of advanced neuroimaging and other predictors of neurodevelopmental outcomes in infants. So, Christina, I'll send it back to you.
Nancy, thank you so much.
Well,
all right, everybody. In a moment, I'm going to be starting the video recording that Yair Blumenfeld filmed for us a couple weeks ago. I'm grateful to him. What I want to just say to you first is this, whether it's a warning, just letting you know that there is videotape of surgical procedures for research purposes on animals. It occurs later on in the recording, and I wanted to let you all know that in advance. So we're going to proceed with the recording. It's going to take me a moment to get it up here, so please just be patient. Thank you.
Hello, everyone. My name is Yair Blumenfeld, and I am really, really sorry that I cannot be there in person with all of you. Unfortunately, I am traveling internationally, interestingly related to some of the work that I will be presenting today. But I want to take this opportunity to, first of all, thank the organizing committee for having me and for allowing me to present like this remotely. And as a consolation, I'm going to have my good friend and colleague, Dr. Susan Hintz, who is very much aware and has been a wonderful collaborator related to all this work, be there to answer any questions during the Q&A session. So with that said, let me begin. All right. So first of all, I have no financial conflicts to disclose, although Stanford has issued a provisional patent related to some of the work that I will be presenting. And we have the following learning objectives. First of all, to understand the pathophysiology and some of the implications of in utero renal failure. I'll spend a little bit of time talking about fetal ludo, which is lower urinary tract obstruction, understanding some of the benefits and limitations of existing therapies, including shunts, and to discuss this novel shunt that we've been working on over the last 4 years or so. So the fetal kidneys really develop quite early in gestation, and the amniotic fluid that surrounds the developing fetus before 16 weeks is made up of predominantly of fluid that crosses the placenta and has other origin. But after 16 weeks, the amniotic fluid that is around the baby is predominantly fetal urine. Fetal renal anomalies as a group are about the second most common group of anomalies after cardiac anomalies. But the more severe renal anomalies, those leading to in utero renal failure, are quite rare, about 1 in 2,000 pregnancies. There are a variety of etiologies for in utero renal failure. These are conditions in which the kidneys and the kidney function is so limited that we have resulting anhydramnios quite early in gestation. You can see those etiologies on the left. I will not be able to talk about all of them, just the two highlighted ones, but I wanted to show you in the image on the right here. You can see here's the fetus, this is the placenta. You can tell there's no amniotic fluid because amniotic fluid is dark on ultrasound. And this is an example of polycystic kidneys that you can see here around the level of the spine. In utero renal failure leads to significant neonatal morbidity and mortality, and not just because of the underlying renal disease. Amniotic fluid is very, very important for fetal lung development. And if we're dealing with conditions in which the amniotic fluid level is quite low here between 16 and 24 weeks, there's a fair amount of fetal lung development that needs to occur that's going to be adversely affected by that condition. And so really the vast majority of neonates with these conditions actually are affected by the lack of pulmonary function, not so much by the lack of renal function. There are obviously associated obstetrical issues related to this, including cord compression, usually iatrogenic early delivery and cesarean delivery. After delivery, if we have a condition in which the fetal kidneys stop to function, there's no way, of course, to grow the kidneys in the neonatal period. And historically, and to this day, actually, neonates need to undergo dialysis. Historically, the dialysis was not hematological based, but rather peritoneal dialysis, in which a catheter is inserted into the abdomen of the baby, and the fluid around the abdomen is sort of flushed to get rid of all the toxins that the neonates make. More recently, there have been major developments in the way in which neonates are being dialyzed, which mimics more the way adults are dialyzed, or hematological-based dialysis. And this has been a really tremendous improvement, not only in the care of neonates, but really has significantly affected what we can do on the fetal side. And the reason for that is that in most centers, in order for a neonate to undergo peritoneal dialysis, the neonate needs to be at least about 2 to 2.5 kilos in size. And for the newer machines, the Aqueducts and the Carpe Diem, the neonate could be as small as 1,500 grams or even smaller. And in many times when we treat these fetuses in utero, there is associated fetal growth restriction and prematurity. And the difference between being able to dialyze a neonate at 1,500 grams or 2,500 grams could be the difference between life and death. Dialysis usually happens until about 1.5 to 2 years of age, at which time kidney transplant can occur. Here's another image of peritoneal dialysis you can see in this neonate. And it is important to recognize that different centers have different size limitations for dialysis. And luckily, I work in a wonderful center in which our neonatologists and pediatric nephrology colleagues can really dialyze very premature, very small neonates. So the question obviously is, what is the role of fetal therapy given the significant morbidity and mortality risk with this? Can we improve lung development, for which conditions, and who are appropriate candidates? And so I want to talk a little bit about infusion as an in utero therapy. Amnioinfusion, which is the therapy in which we insert a needle into the amniotic cavity and inject fluid, is not a novel therapy. Here's an example of a manuscript from 1994, you can see, and there have been others, but I included this one for a reason. This was a case in which a fetus was diagnosed with absent kidneys altogether, or what we call bilateral renal agenesis. This group performed serial amnio infusions between 17 and 33 weeks gestation. When you perform amnio infusions, the fetus swallows the fluid, and because the fetus is not making any urine, you have to perform this multiple times. In this particular case report, they were successful in getting the fetus to 33 weeks. They needed to deliver at 33 weeks. And actually, the group showed that the lung development was appropriate. The child actually survived the initial couple of days. Peritoneal dialysis was started, and unfortunately, the child passed away because of complications related to dialysis. On a postmortem scan or a postmortem exam, what they showed was that in addition to the complications of the dialysis, there was actually quite significant neurological injury in the survivor. And I want to put a pin in that and come back to it later. But what the authors concluded back in 1994 was that at present, i.e. in 1994, this type of procedure is not an appropriate intervention in case of renal agenesis, and as such, management is strongly discouraged. And there was really sort of a moratorium on this type of intervention for these indications. Fast forward about 20 years, and a group from Johns Hopkins published a case report in which they performed in utero serial amnio infusions in a fetus that was diagnosed with bilateral renal agenesis. Lo and behold, the neonate survived. Pulmonary function was appropriate in the neonatal period. They began dialysis, and actually this child was then transferred from Johns Hopkins to Lucile Packard Children's Hospital. And the child was actually the daughter of a very prominent congresswoman from Washington State. And this particular congresswoman then went on to not just the medical press, but actually the lay press to highlight this magical intervention called serial amnio infusion for a disease that was actually deemed to be universally lethal. A couple of years later, as the floodgates opened into different groups performing this on the heels of this very successful case report, a group got together and asked, well, we know that there's at least one successful case report, but we don't know how often this has been tried. We don't know how often other groups have trialed and failed. And we really don't know what the risks are, not just to the fetus and neonate, but actually to the mother. And the group, which included several ethicists, argued that serial amnio infusion should not be offered as a treatment, but rather as innovation or research. And then a multidisciplinary group then convened at Johns Hopkins and argued that there is a need for multi-center collaboration in this area and that nobody should be doing this by themselves. This is the technique. The image on the left is the needle going into the uterine cavity over here, traversing the membranes. Eventually fluid is then, a pocket is created with a little bit of fluid there. And you can see in the video on the right, there's now a fair amount of fluid around this fetus. And again, the point is that even though it's a needle-guided, ultrasound-guided needle procedure, it is a procedure that is invasive, and multiple procedures need to be performed during the course of the pregnancy. And so there was a fair amount of unknowns several years ago, including what is the optimal time to start the amnio infusions, what is the optimal frequency, what's the fetal benefit, the maternal risks, who should be doing this, and what kind of oversight should there be. And this really launched a multi-site study called the RAFT trial, which is renal anhydramnios, not renal agenesis, but renal anhydramnios fetal therapy trial, which was or is still sponsored by the NIH, the NICHD. And the aim of this trial is to evaluate the safety, feasibility, and efficacy of serial amnio infusions for early in utero renal failure or renal anhydramnios. As a subset to that, the aims are to determine the maternal and fetal safety and feasibility, to examine the short-term efficacy, which for the trial purposes was defined as survival to 14 days. And this was really developed because in utero renal failure was expected to be 100% universal within the first day of life, day or two of life. And so if a neonate is able to survive to 14 days, clearly there are pulmonary benefits to serial amnio infusions. And of course, everyone is interested in long-term efficacy, both survival and quality of life. This is a multi-center, non-randomized clinical trial, which started in Johns Hopkins. We were the second center, and then ultimately 6 other centers joined, and more recently, Washington University in St. Louis and Boston Children's have joined as well, and you can see those on the map there. There are actually 2 arms to the trial, and I think this is very appropriate and very much shows great foresight to the people that developed the trial, where they separated the bilateral renal agenesis group, the presumably most severe etiology of in utero renal failure, from what's called a fetal renal failure, or the FRF group, which is really a sort of a basket of a variety of etiologies. The plan was to enroll 35 patients in each arm. Patients can be enrolled and decide that they either go the intervention, which is the serial amnio infusion, or they might want to enroll and just undergo expectant management, meaning they don't want to have the intervention, but they want us to study the natural course of the disease. And of course, all the patients are offered and declined pregnancy termination. The outcomes of the trial, you can see again on the left, the primary outcome is a 14-day survival to successful dialysis. And secondary outcomes include maternal safety, serial amnio infusions, the number of amnio infusions, survival to transplant, which again would be at about 2 years of age, and quality of life long term. Many, many inclusion and exclusion criteria. Don't worry, I won't go through each one of these one by one. I do want to highlight in terms of the inclusion criteria, both for the bilateral renal agenesis arm and the fetal renal failure arm, there must be confirmed absence of amniotic fluid by 22 weeks of gestation. Again, we would expect that because that transition of amniotic fluid happens at 16 to 20 weeks. So if the fetus is not making any urine because of in utero renal failure or absence of 2 kidneys, we would expect anhydramnios by 22 weeks. And because there's a fair amount of evaluation and intervention and other things, the first trial amnio infusion needs to occur by 26 weeks of gestation. Many, many exclusion criteria, both medical and social, things that increase the risk for prematurity or technical issues related to the procedure there. As of today, when I'm recording this talk on March 4th, 2024, it's important to highlight that the Data Safety Monitoring Board met in the spring of 2022, now almost about a year and a half ago, as they do, to analyze the outcomes of patients that are recruited. This is obviously a highly investigational number. And after 18 patients were enrolled into the bilateral renal agenesis arm of the study, the Data Safety Monitoring Board decided to halt recruitment into that part of the trial and to no longer allow us to recruit patients. And the reason for that was twofold. First of all, the expected number of patients to survive in the absence of amnio infusion, of course, is 0. The actual number of patients that survived to 14 days that met the primary outcome was 77%. So obviously a resounding success in terms of meeting the primary outcome. Again, at the time of the launch of the RAFT trial, nobody knew if these types of neonates can survive beyond 1 or 2 days. The RAFT trial has shown without a doubt that neonates can survive the pulmonary issues with serial amnio infusion. However, despite that successful element, the Data Safety Monitoring Board had concerns about death beyond 14 days. So while 14 to 18 out of 18 met the primary outcome, which was 14 days, only 6 survived to discharge. The remainder succumbed to either infection, other issues related to prematurity, complications from dialysis, etc. And among survivors, there was a non-insignificant neurological morbidity, namely strokes, that are currently being analyzed. So similar to what was seen in 1994 in that case report. Recruitment into the fetal renal failure arm is ongoing. The Data Safety Monitoring Board did review those outcomes from that cohort and deemed it safe and appropriate to continue to recruit. And just to give people more or less a ballpark, out of the 35 patients that the trial is looking for, the study has already recruited about 27, and those data have not been analyzed formally. Data from the bilateral renal agenesis arm aspect of the trial have been reported late last year, and you can find those in PubMed. You can see that here. Once, certainly neonatologists, but the multidisciplinary graft cohort started having survivors, clearly what became evident was that there may be differences in the way that these children are managed within different NICUs and centers. And I wanted to highlight a research letter that was just published by the neonatology subcommittee of the RAFT trial, highlighting these differences and highlighting the knowledge gaps in the way that these neonates are managed. So you're welcome to read more about that there. This is an example of one of the bilateral renal agenesis arm children. Moving now to fetal lower urinary tract obstruction, which is another complex renal disease that we find in fetuses. First of all, it's important to note that LUDO, or lower urinary tract obstruction, is a finding, not a diagnosis. It's something that we see on ultrasound. And there is a differential diagnosis, which you see here on the left. Oftentimes, yes, it is because of something called a posterior urethral valve, whereby a small membrane obstructs the bladder or obstructs urine from exiting the bladder through the urethra. This is a condition that is more often found in males, but there are other etiologies, including anteurethral valves, urethral atresia, stenosis, genetic abnormalities, multisystem abnormalities, et cetera, that you can see there. And so when we perform ultrasound, we suspect LUDO. It's not always that we can come up with the underlying diagnosis. On the pictures on the right, you can see gross histology from a case which decided not to continue the pregnancy. And this is a histological picture on the lower right of a kidney. And you can see the renal cortex, or take my word for it, is quite thin. The collecting areas are dilated and quite distorted from the pressure of the urine. This is an example of what LUDO looks like even in the first trimester. You don't need to be an ultrasound expert to know that that large circle within the fetus, and you can see the comparison of that large circle compared to the size of a first trimester fetus, is not normal. And even in the first trimester on the ultrasound picture on the lower right, you can see those kidneys are quite dilated and what we call hydronephrotic, or have a lot of fluid within them. Now, interestingly, you can see in the first trimester that there's still fluid around the baby. That's because, again, the process of transitioning of the amniotic fluid to fetal urine has not yet happened. And then in this cartoon, you can see the obstruction here in the bladder becoming large, and this is called megacystis, or large bladder, urine going back into the kidneys, causing hydroureter, or water in the ureter, which we don't normally see, and then these large hydronephrotic kidneys there. Over time, when there is decrease of amniotic fluid, again, the primary morbidity and mortality is a pulmonary one. And even though this is a very, very small abnormality in the urethra or bladder outlet, it is associated with an up to 80% mortality in severe LUDO cases where the obstruction is complete. About 30 years ago, people realized that this obstruction is quite severe, profound, and has significant clinical outcome associated with it. And a vesico-amniotic shunt was developed. These are catheters that are placed within the bladder, over here in the cartoon, bypassing the obstruction and allowing urine, fetal urine, to then go into the amniotic cavity. The idea is to increase the amount of amniotic fluid, decrease pulmonary compression, allow the lungs to grow more appropriately, and to lower the morbidity and mortality. Multiple sites have shown that performing vesicoamniotic shunts in cases of severe LUDO can decrease pulmonary morbidity and mortality. However, the benefit on the genitourinary system, on the kidneys and the ureters and the bladder, has not been shown to be definitive. And many of these children still need to undergo dialysis and transplant if they survive the initial neonatal period. These are the two most common shunts that are used in the United States. The shunt on the left, the vesicoamniotic shunt on the left, called the Rocket or Rodick shunt, was actually developed in the United Kingdom by Charles Rodick. The shunt on the right, or the Harrison or the Cook shunt, was developed by Michael Harrison at UCSF. You can see that both have similar designs. They have these pigtail catheters on the end. The Harrison shunt is a little bit smaller and more malleable. The Rocket is a little firmer. But I wanted to highlight that each one of these shunts needs, in order to place it, we need to use these trocars, these sharp trocars that go through the maternal abdomen, through the skin, through the uterus, sometimes through the placenta, through the fetus, into the bladder, and then to deploy it. And obviously, this is a sharp instrument, and you can already start to imagine the kind of complications that one might encounter. As an aside, the Rocket shunt is actually currently on hold in the United States due to manufacturing issues, so we're really actually only left with a Harrison shunt. There are several other shunts around the world. There is one particular shunt in Asia that hasn't been marketed extensively, a double basket shunt, and one more shunt out of Germany called the Somatex shunt, which hasn't been marketed extensively as well. But if you read about those, I'm happy to discuss those at a later time. But these are the most common shunts that we use today. And this is what it looks like. So you can see the trocar going into the bladder on the left-hand image. In the middle image there, you can see the part of the shunt that then gets deployed into the bladder. And then the image on the right has the shunt once it is deployed. And I want to turn your attention over here to the picture on the right-hand side and highlight a few things. First of all, while you can see the part of the shunt that is within the bladder quite well, it's very hard to see the part of the shunt that is outside the bladder. And that is one of the limitations of existing shunts. The second thing is that the bladder, which was quite dilated before, is now quite thick and decompressed. And even if the shunt is placed appropriately, and even if there is no dislodgement of the shunt, that decompressed non-functioning bladder continues to become non-functioning, and after birth continues to have significant dysfunction. And over time, because the bladder is not functioning well, there's backwards flow of urine into the kidneys, ongoing destruction of the kidneys. And even if the child ultimately has a renal transplant, the new healthy kidney that was transplanted will actually be adversely affected by this non-dysfunctioning bladder. Thinking about the potential complications of vesicoamniotic shunting, we can see maternal risks, including bleeding and infection. So we perform these cases, at least at OPCH, in the operating room under sterile technique with antibiotics. There's obviously a risk of fetal trauma. The fetus is quite small, sometimes in the second trimester. So you can imagine a sharp trocar going into the bladder at that gestational age. It's also important to note that these shunts, while they were developed for the fetal bladder, are also used to bypass or remove fluid from pulmonary conditions such as pleural effusions and large cystic lung masses. So we also deploy these in the chest, and you can imagine trauma in the chest where there's a lot of vascularity and other vital important organs. Obviously, we have to traverse the uterus and the membrane, so there is a significant risk of chorioamnionitis or infection of the membranes, preterm premature membrane rupture, chorion amnion separation, abruption, and preterm birth. But really, the Achilles heel of vesicoamniotic shunting is shunt dislodgement. Something in the way that these shunts were created leads to them being dislodged or to migrate during the course of the pregnancy, sometimes as high as 50%, maybe even higher. So when we counsel patients about the need for shunting or consideration for shunting in these cases, we explain to them that there's a fairly high likelihood that this will not be a one and done, and that all of these complications, the maternal, the fetal, and obstetric, we might need to have the patient undergo this again, and each procedure has those types of complications. And obviously, placing the shunt does not help us with making the diagnosis. Because of the limitations of shunts, about 10 years ago, people hypothesized, well, maybe fetal cystoscopy is the way to go. maybe instead of putting a catheter between the bladder and the amniotic fluid, we can actually insert a scope, a fetal cystoscope, into the bladder of the fetus, take a look at the bladder outlet, identify whether or not a membrane exists, and actually use a small laser fiber. You can see the laser here on the posterior urethral valve, and ablate the valve so that we perform primary repair rather than a palliative measure. Unfortunately, while there was some excitement about this initially, what subsequent studies have shown is that if you put a cystoscope in a developing fetus and you start using a fair amount of heat, like with a laser, sometimes you can have unwanted outcomes. And in this case, there was a fistula that you can see here. Subsequent studies have shown that much of this is because of the angles in which you have to navigate the fetal bladder and outlet. So while it's reasonably, it's reasonable to actually place a fetal cystoscope to navigate those angles and make sure you're on the right spot and use heat, you're talking about a very, very small size. And this was a group from France that showed using MRIs that the angles are not quite there. And there are several groups around the world working on developing new cystoscopes, and this might be the future. But for the time being, we are left with shunts. So far, I spoke about the morbidity on the individual level, but we have to think also about the healthcare burden in terms of its financial implications. Because of the preterm premature membrane rupture risk and prematurity risk, each of these cases has a not insignificant amount of financial implication in terms of neonatal care and the dialysis and lifelong renal care for each patient. And you can see we made some assumptions in terms of the number of these cases that currently undergo therapy in the US, and the numbers become quite robust. I want to highlight this is one of our former patients. Play this video, hopefully you can hear.
While I was pregnant with Caleb, he received 5 separate shunt placement surgeries in order to save his life. And because of the shunt, we believe that that is the reason Caleb is here today and has life. And we are really excited to hear about this new design and how it can help so many other kids just like Caleb.
So this was Mandy and Caleb. You can see here, this is pre-COVID. As you can tell, we all look much younger. But Caleb was one of our patients and is still a part of the Packard family, required multiple shunts, ultimately had dialysis and transplant. But clearly, because of the limitations of the shunt, we needed to perform this multiple times. So about 4 years ago, I was invited to join a multidisciplinary group that was brought together by James Wall, who you can see here on the right. And James is a pediatric surgeon and the head of the pediatric subsection of the biodesign program here at Stanford. And he brought together the 4 of us, starting with Kuhn Scheth, who's a pediatric urologist and takes care of these children after delivery, Eric Johnson, who's a bioengineer by training and works with several prototypes, and then myself and Enrico Danzer, who was a pediatric and still is a pediatric surgeon. At the time, he was a fellow here at Stanford, and now he takes care of children with malignancies at Memorial Sloan Kettering. And the idea was to bring us all together and to think about novel ways in which these shunts can function and maybe improvise and improve the technical specification of existing shunts. And so this was our original prototype, what eventually became known as the Vortex shunt. And so first of all, you can see that the ends of the shunt or the anchors of the shunt are no longer pigtail, but rather these nitinol umbrella type anchors. And in the first prototype, we actually used off-the-shelf atrial septal defect closure device where Eric just pulled them apart and stuck them on the end of a stem, which includes nitinol covered by a polyurethane there. And the idea was that maybe by using these umbrella type anchors, we can then increase the force in which one would need to remove them so that they wouldn't just come out as the baby is moving around or growing in utero. The other improvement that we thought of was placing a one-way duckbill valve within the stem of the shunt. And the idea there is to allow for bladder cycling so that urine would not just flow freely, thereby leading to that contraction of the bladder. but rather there would need to be a certain pressure within the bladder in order to overcome the opening of the valve. So thereby, in utero, if this works, we can mimic normal bladder cycling. So once we created the prototype, the first thing we wanted to see, well, what is the pull force that you would need to remove it? And we created this sort of on-the-shelf or benchtop model using a pig bladder. And using this manometer, you can see that once you insert the shunt into the bladder, it takes a lot more force to remove the vortex shunt compared with the rocket shunt or the Harrison shunt. And we think that a lot of the reason these shunts dislodge is because as the fetus is moving or growing, it becomes quite easy for these shunts to migrate either within the bladder or outside. We then created this sort of benchtop model using, you can see a pig bladder there, and you can see the ultrasound picture on the right, which looks very similar to a human, even in this rudimentary model. And you can see how well you can see the shunt there by ultrasound. And we showed that we can deploy the shunt even in this, what looks like a rudimentary model there, using a pig bladder. And we were very excited when this happened. This was all in Eric's garage. You can see that our early prototype can bend and extend in ways that existing shunts cannot. So if we could deploy this correctly, even as the fetus grows and moves, we felt quite comfortable that there would still be a conduit for that urine to escape the obstructed bladder. We then performed benchtop testing in which we analyzed the water pressure that would be necessary to overcome that one-way valve. And we were happy to see that the water pressure mimics what the bladder pressure is in a newborn. And we think that this has quite significant biologic plausibility to work. So we took all that data and we published that about 2 years ago now, and you can read more about that there if you'd like. Over time, rather than using off-the-shelf ASD closure devices, Eric was able to start to develop the whole thing by himself in his garage. And so we purchased nitinol. He started to manufacture this in his garage to our specifications. And you can see that the Vortex, what we call 2.0, starts to look like an actual medical device. There's a sterile steel end there. The fixations were optimized. And you can see that we can now control the size of the anchors and also the size of the overall shunt. I'd like to highlight that the shunt delivery system is quite different from existing shunts. It mimics IVC filter device delivery systems rather than shunt delivery systems. And there are a couple of technical improvements there that I just unfortunately don't have time to get into, but it is novel as well. So we took this Vortex 2.0 shunt and we went back to benchtop testing, looking at the kinking and the deployment. And we were happy that we had similar to success to the original versions. You can see the trocars over here. And sometimes we use pig bladder, sometimes just simple silicones. And again, this canister with the ultrasound probe. Once we could control the manufacturing, we can develop these trocars and shunts in different sizes. And the idea there is that because we use this both for the bladder and the lung, and because we might deploy this at different gestational ages, we might need different sizes and lengths. Trocar length is obviously important because obviously our patients come in different sizes and we might need different sizes because of that as well. On the left here, you can see some of our kinking analyses and benchtop tests. This is actually the rocket shunt that you see in the picture on the left. Once you kink the rocket shunt, it obstructs the stem. And with our shunt, we didn't see that. So once we concluded the benchtop test, we then wanted to see whether this shunt works in an animal model. And as many of you in the audience know, most of the animal models that have been used throughout the ages to study obstetrical outcomes have been sheep models. And so we started calling our colleagues around the United States who we knew were working with sheep. And many of them were either not interested in Ludo, or the cost was going to be prohibitive, and there actually aren't that many labs using sheep. But luckily, our friend Enrico Danzer, one of the members of the team, had a connection with a group in Leuven in Belgium. And the nice thing about the group in Leuven in Belgium, first of all, is that it is headed by a prominent fetal therapy expert named Professor Jan de Prest. And Jan has a very storied track record of fetal medicine and therapy experience, and is very well published. And the group in Leuven was interested in understanding the pathophysiology of ludo. And so they created this surgical model in a sheep model where they obstructed the urethra or the urachus, and they were really just interested in studying the pathophysiology, meaning why is it that ludo leads to kidney disease or pulmonary disease. A sheep gestation is usually 140 or so days, and they created the model surgically at 70 days. And you can see using their model by the time of the end of the pregnancy, in the sheep, again, or the lamb in this case, obviously the bladder is distended just like in the human. There's hydronephrosis just like in the human. And it was very fortuitous that they had this lab, that they were interested in ludo, that they created a model, that Enrico, our partner, had a connection with them. And we said, let's collaborate. And they said yes. And we are very happy about that. And so about 2 years ago now, Enrico flew over to Leuven. And at the end of the gestation, he said, okay, let's see if we can at least get this shunt into the lamb or sheep model. And I want to highlight a few things. First of all, in this picture here, you can see our shunt deployed within the lamb model. You can see how well you can see the part of the shunt that is within the bladder or chest and the part that is outside and the stem. So this is a major, major improvement compared to existing shunts. And here you can see the shunt in its entirety here. This is the bladder that is now decompressed, and you can even see fetal urine coming out. So this was deployed, these shunts were deployed at the end of gestation, and we were very, very excited. You can see this is from July 2022. At the time, they also created a pleural effusion model where at the end of gestation, they just injected some fluid into the fetal chest, and they were able to deploy the shunt you see here into the fetal chest. This is again at the end of gestation, and you can see how well you can see the shunt here within the fetal chest immediately after deployment. After deployment, they sacrificed the animals, and they verified the correct placement both in the bladder. This is the part of the shunt that is in the bladder, and the part that is outside, and the part that is within the chest. And so there was accurate deployment both in the bladder and the lung at the end of gestation. Over the next couple of months, Eric started to collaborate with various manufacturers, developing the prototype, optimizing the prototype, and creating these shunts in his garage in a more optimal setting. And you can see that we were able to not only develop them, but actually package them, sterilize them. This is starting to look like a medical device, and start to take it with us to Leuven as we were conducting additional studies. The next study that we wanted to do after proving that we can deploy these shunts both in the chest and the bladder at the end of gestation was we wanted to see whether or not we could actually deploy them at gestational ages that mimic the gestational ages that we deploy them in humans, namely in the second or early third trimester. So what we did was, again, these models are surgically created at 77 days. And at 100 days, so not at the end of gestation, but about 3 to 4 weeks afterwards, you can see what the ludo model looks like. Again, we see hydronephrotic kidneys here. These are not the eyes. These are the very dilated kidneys. You can see an enlarged bladder, just like in the humans. You can see a little bit of ascites here where there's some urine coming out of the bladder, and that happens in humans with ludo as well. And so again, 3 to 4 weeks after the ludo is created, we see all the characteristics of ludo, the keyhole sign in the bladder that's dilated, bilateral hydronephrosis, and decreased fluid around the lamb. And what we then showed was that we can actually deploy the shunt at these earlier gestational ages. And so what you're seeing here is the trocar going into the bladder, and you can see this shunt within the fetal bladder here and in the amniotic cavity at a gestational age that we are very much interested in, just like in the human. And this time around, we did not sacrifice the animals right away, but we waited 24 hours to see whether or not the shunt would still be in place. And so at 24 hours after deployment, we came back and we were very happy to see that the shunt was still in place. The bladder is now decompressed. Let me show that again. The bladder is now decompressed and the amniotic fluid is still there. We then sacrifice the animals. And all of those studies are ongoing, and we're performing both functional and histological studies to see the benefit. We similarly performed a feasibility study at mid-gestation for pleural effusion. You can see the ultrasound video there on the bottom and center. And similar to the bladder, we did this at 98 days of fetal gestation, ultrasound guided, and then waited 24 hours. And 24 hours later, the shunt was still in place. And this is through the chest. These are the ribs. And you can see the part of the shunt that is within the chest, the part of the shunt that is outside, and no dislodgement happened after 24 hours. So these data were then published about 6 months ago in Prenatal Diagnosis. And if you want to learn more, you can see that there. So really, over the last couple of years, in 2022, we proved that we could deploy this shunt in a ludo model at full term. Last year, we proved that we could deploy the shunt at mid-gestation. And so the question really now is, how long will the shunt remain in place if we deploy it at mid-gestation? And what is the effect on the developing lung, bladder, and kidneys? And those studies are ongoing. And actually, this is the reason why I am not with you guys today. I'm actually in Leuven, Belgium. What about the potential cost benefit if we can reduce the shunt? This was a study that was spearheaded by Jamie Schlachter, who was actually a medical student at NYU, who partnered with Kunj, the rest of the team, and a couple of our collaborators. And what we wanted to see was, in a theoretical analysis, if we took 1,000 ludo cases, and if we could decrease the dislodgement rate from 50% to 10%, what would be the effect on end-stage renal disease, meaning the renal morbidity, and what would be the effect on the prematurity, or specifically the neonatal neurodevelopmental outcomes? And what we showed was that if you again took 1,000 theoretical ludo cases, and if you could decrease the dislodgement risk from the standard 50% to 10%, you would end up with 60 fewer cases of end-stage renal disease and 10 fewer children with developmental delay, with a potential estimated lifetime savings of about $130,000 for each case. We also analyzed differences between 50% and 40% or 30% or 20%, and you can have tremendous both clinical and cost savings if we can decrease this dislodgement rate. Obviously, this was a theoretical cohort. We're waiting for these animal studies and, of course, future, hopefully, first-in-human studies to tell us the exact. So what are our next steps for 2024? We have some MRI compatibility studies related to our shunt that we're performing, because oftentimes patients who have these shunts undergo fetal MRI to look at the effect on the lung. We're in the middle of clinical efficacy studies, which are scheduled, of course, now and in the summer. We've started on discussions with the FDA just to verify that our animal studies are appropriate for what they would need to see in order to get to a first-in-human trial. We're in discussions with strategics and other partners. Again, we're looking for funding sources. And if anybody has any ideas, I'd love to hear from you. Please reach out. You can get my email, I'm sure, from the organizers or even my cell phone. And then finally, I want to highlight our fetal and pregnancy health program, which is an amazing place. Obviously, I'm biased, but really just an incredible multidisciplinary group of individuals that are really trying to innovate and, more importantly, just take care of each and every patient and family to the best of our ability. And we've just seen a blossoming of the volume of patients and the interventions that we perform, the analyses and the evaluations that we do, not just for fetal therapy cases, but just fetal anomalies in general. And I feel truly blessed to have all of my colleagues as friends and professional collaborators. And so with that said, I'll stop here. And I know that Dr. Susan Hintz, who is the medical director of the Fetal and Pregnancy Health Program, is very much aware of all the work that I presented today. And I'm sure we'll be able to answer all of your questions, both for my presentation and our Fetal and Pregnancy Health Program. So thank you, and I will stop here.
Susan, thank you. Thanks for joining us. It's totally cool to have you. You know, whoops, hold on, everybody. That is nothing on you, Susan. Sorry. I do want you to be here. I'm not trying to kick you away. I just want to say thank you for joining us again. And I want to start off with this because I just think it says it all. And that was one of the comments that came in, and they said, wow, talk about collaboration.
Yes.
Started off with that.
Yeah, well, we are very fortunate, and Yair has obviously done a great job of collaborating among his colleagues. It's kind of a small group of MFM fetal interventionalists, but also those MFM fetal interventionalists are very much interested in more minimally invasive approaches that will work consistently. So there's a lot of biomedical technology communication that is going on there. And just in general, in our fetal and pregnancy health program, it is an extraordinarily multidisciplinary and collaborative group. You know, obviously, as Yair said, there's kind of a small group within that group that could even potentially be candidates for an intervention. The vast majority of the patients that we all care for together, and I mean together because it is a continuum of care group, really are patients that are not eligible for any kind of intervention. They have diagnoses that are not amenable to any interventions.
We'll talk about that because when does diagnosis occur for most of these conditions?
Yeah, well, I mean, it's a broad range of different conditions. Just focusing on what Yair talked about in this presentation, it can be very early. And as Yair mentioned, you know, the majority of amniotic fluid is made by the fetal kidneys after 16, 17 weeks. So it can be a very early identification, for instance, of bilateral renal agenesis. So these can be made quite early on. There are many anomalies that are identified or are suspected and further, you know, referred to us or elsewhere for additional studies or additional imaging after the initial 20-week anatomy scan.
I managed in my former life, I managed a department of OBGYN ultrasound. And I want to do a shout out to all sonographers because, you know, their specialty is key to all this. So why don't we answer that first one? If a fetus has bilateral renal agenesis, does the bladder develop?
It is a great question, and it actually goes to the need for really, you know, profound multidisciplinary discussions with families in advance and, you know, during the RAF trial and preparation. So it's a great question. Just from an embryologic perspective, there may be some little bud of something that was meant to be a bladder, but literally if the ureters don't meet it, that bladder is not going to develop. And if there is not fetal urine, that bladder is not going to develop normally. So the quick answer is that there's really not a fetal bladder. So, you know, I think that probably that question goes to, well, even if you were successful in these cases, say in the RAFT bilateral renal agenesis arm that went on to be discharged and are now on the path to transplant, what does that mean? Or in some of these past cases that were not part of a trial. Well, the ultimate experience for that patient will mean probably a neobladder construction from a part of bowel. So it is a great question because it really goes to the very long and very complex journey, even in the best of scenarios, even if all the steps were as positive as we can imagine for these patients and for their families.
Wow. What about talking about infusion or dialysis and strokes?
Right. Okay. So that was, I think it's also a great, it's a great point, and I'm glad that Yair talked a bit about the bilateral renal agenesis arm of the RAF study, of the RAF trial, which is still ongoing, because this is a perfect example of how multiple groups and specialties really had to merge together to make this happen. And unfortunately, you know, the technology and the approaches to treatment for neonates, and especially small babies, premature and very low birth weight infants, who require neonatal renal replacement therapy, was really in evolution and remains in evolution. So there really had not been a huge amount of experience with what these babies would do, and what kinds of complications there would be. Now, why could there be stroke? It is an absolutely great question. One of the things that on the neonatal side that was recognized in these babies in particular, more so than in the fetal renal failure for other anhydramnios reasons, was some profound and really, you know, refractory hypotension. And we had experience with that in our group here. And I'll just have a shout out to Sheila Rasdin, who led a recent case report, and she actually presented to this group yesterday, along with my colleagues, Dr. Valerie Chalk and Dr. Alexis Davis. Dr. Davis, who is the medical director of our level 4 NICU and also the medical director of our nephro NICU. And what was recognized was this, you know, not just for us, but with other groups, a profound refractory hypotension. And in our group, this case presentation or case report that was published, I want to say the end of last year, no, or beginning of this year, in pediatrics, really demonstrated that that not only discussed the finding, but also the novel use of angiotensin II. And so this angiotensin II, you know, just taking many steps back, you can think of renin, which catalyzes the conversion of angiotensinogen to angiotensin I. It's primarily produced by the kidney. So it's plausible that bilateral renal agenesis may lead to this kind of complication. But I will say this is a very small number of patients, as you could see, that we have this kind of information on, because even later in just, even if the baby initially survived, they may not have shown these this kind of profound refractory hypotension. So
this is my question, and it may be a crazy question. I'm going to throw it out there. So I know of researchers that are trying to mimic breast milk, absolutely as close as you can get to breast milk for those that can't use it or unable to produce it. Is there any work going on trying to mimic amniotic fluid?
Yeah, so that's a great question, Christina. And of course, there are many different, you know, growth, you know, maybe growth factors that are not included in just the infusions that are provided to in the amnio infusions in this kind of study situation. I think most people are kind of focused on whether and under what circumstances even this kind of amnio infusion would occur. Now that there has been this this study, and there are lots of questions around that ethically and in terms of under what circumstances and in which groups this might even be reasonable to undertake. But certainly there are questions about whether the fluid that's being used is just, basically saline is actually effective, or if there are other growth factors that might be added to make things work better.
Right, right. Okay. I think I've got one more here. Let me see what this was. What about improved outcome for bladder function?
Improved outcome for bladder function in luteal?
Yes.
Well, I think that our urologists, in combination with other biotechnical collaborations, are always trying to, make steps. I think there is a range of issues, and I see one of the comments has to do with somebody who took care of a patient that Dr. Blumenfeld took care of a patient whose fetus had luteal. And as probably the group on this meeting right now knows, there is a range of issues that may be seen in the bladders of babies who have luteal, because as Yair mentioned, luteal is kind of a broad range of potential different diagnoses. So it is a major issue, and I'm glad that you brought it up, that this is something that has to be discussed, not just, what's going to happen during the pregnancy, what's going to happen in the first, days to weeks in the NICU, but what does the entire journey look like, and what are the challenges for the patient and the family that may include things like bladder function being absolutely not useful, maybe needing to have a completely new neobladder constructed, how the urologists will approach that, and maybe not even have an answer in fetal life.
Incredible. Susan, I think we're going to call it a day. I think you know what? We are like right on time.
Okay. Well, thank you very much.
Thanks for your help. We really appreciate it. I love the comments. Take care of yourself.
Okay. Thanks very much.